All right, I think we are at a great spot, so I'm going to go ahead and get started so that Dr. Irizarry Gatell can spend as much time with us today as we have allotted. And thank you so much for spending your lunchtime with us. My name is Alex Huffman. I'm the Director of Supportive Care and Integrative Oncology at the Cancer Center. I've had the pleasure of hosting this Lunch and Learn series since we started, and I'm really excited to see some of you returning, some new names, and I hope that this is a time of information and connection for many of you. I'm going to start with just a couple of housekeeping rules. The first is that this is being recorded, and you will receive a recorded copy along with some great resources as a follow-up next week. We did get a few questions in advance, and if you have additional questions or some come up, please go ahead and put those in the chat throughout the session, and we have time at the end where Dr. Irizarry Gatell will answer those. I am really pleased, and thank you so much, Dr. Irizarry Gatell, for being with us today. To introduce you, you are a medical oncologist here at UT Southwestern Simmons Cancer Center. She specializes in acute leukemia, bone marrow transplantation, and cellular immunotherapies, adult and young adult oncology, and survivorship. Dr. Irizarry Gatell's research interests include survivorship outcomes of patients with leukemia and those who have undergone bone marrow transplantation and other cellular therapies. Certified by the American Board of Internal Medicine in Internal Medicine and Hematology, Dr. Irizarry Gatell joined UT Southwestern's faculty in 2023. When she's not at work, Dr. Irizarry Gatell enjoys baking, cycling, dancing, traveling, and going to museums. Awesome. Thank you so much. We are going to turn it over to you to get into this really, really important topic today.
Thank you, Alex. Yes, it's exciting to see how many people are really interested in something that I have become really passionate about throughout my career. So as Alex mentioned, I joined UT just a couple of years ago, and I am an assistant professor in the Division of Hematology Oncology. And today I'm going to be talking to you about one of my favorite topics, and mainly because this is the patient population that I treat, and we're going to be talking about blood cancers in adolescent and young adults. And I'm going to really try to hone in on treatments for this patient population and how they're different than other populations, supportive resources, and kind of another one of my favorite topics is survivorship. So we'll touch all of those points today. I want to be honest with everyone. I have no conflicts of interest to disclose. And, before we get started, I really want to be clear about who we're talking about and who an AYA or an adolescent and young adult is, because I'm going to be using that term AYA a lot in this presentation. AYA, as I mentioned, stands for adolescent and young adult. And in the cancer world, this describes any individual with cancer between the ages of 15 and 39. This is a definition that was originally described by the NCI, or the National Cancer Institute, back in the 1990s, when researchers and clinicians were trying to look more closely at this population's outcomes. But I think if you talk to any of my patients in my clinic, you'll notice that they feel like they're the only person their age that has this cancer. But as a researcher, I know that this isn't true. Estimates suggest that this year, in 2025, by the end of it, there will be approximately 85,000 new cancer cases in the AYA population. And this accounts for 4.2% of all cancer diagnoses in the US. In fact, the rates of new cancer cases among AYAs has actually been on the rise since 2013. And as you can see here in these two graphs, the one on the left-hand side is a graph of new cancer cases in adults over time, whereas the one here on the right is of new cancer cases in AYAs. And as you can see, the rates of adult cancers have really kind of stabilized and maybe even gone down over the past couple of years. But AYAs have definitely gone up, and on average, it's gone up about 0.3% each year for the past 10 years. Now, when we look at what types of cancers are affecting our patients, blood cancers are some of the most common. So this is a table of leading cases of cancer, or causes of cancer in AYAs. And as you can see, blood cancers are very prevalent throughout all age groups. So we tend to call AYAs who are 15 to 19, young AYAs, those who are 20 to 29, intermediate age, and then those who are 30 to 39, older AYAs. And you can see that the blood cancers are really prevalent in young AYAs, and then a little bit more prevalent in intermediate age, but it seems like they kind of drop off in breast, thyroid, melanoma, and colon cancer take over in the later AYAs. However, if you look at sheer numbers, the number of patients with blood cancers in the older AYA range far surpasses that in the younger groups. I also think it's important to know that cancer is becoming more and more deadly in our AYA patients. Around 9,000 young adults die from cancer every year. And at the moment, official stats say that cancer is the 5th leading cause of death in young adults, although some stats are starting to say that they think it'll surpass heart disease and become the 4th leading cause of death in young adults in the coming years. But if you look at the survivorship literature, and to kind of explain what a survivor is someone who medical doctors and physicians say has been cured of their cancer. These patients who have survived their cancer actually report higher rates of suicide, heart disease, and other cancers compared to the general population. So as if having cancer just once was bad enough, the treatments associated with the cancer can cause a lot of morbidity and mortality in a very young patient population. Now, the most deadly cancer in the AYA population is leukemia, and we'll talk about why a little bit in the rest of my talk today. But if you look here, the overall 5-year survival rates for AYAs with leukemia is about 60%. And if you compare this to survival of other malignancies, the other malignancies have anywhere from 83 to 86 5-year survival rates. So leukemia is quite deadly, and in most AYA age groups, it's the most deadly cancer that is present in this population. And while the numbers of mortality from leukemia are motivating enough for me to treat this group, I think there's something else that really drives my passion for really wanting to help these patients and why I got into this field in the first place. And it's really something that goes beyond the science and the numbers, and it has to do with the priorities of the patient and the priorities of our goals for their treatment and our goals for their survivorship. So don't get me wrong, I love my older adults with leukemia, but when I talk to an older adult with leukemia, it's so different from talking to one of my AYAs. Their priorities are just different. You know, where my older adult patients might be, not super surprised that they've had cancer because they know a lot of other people with cancer, my young adult patients are saying, aren't I too young to get cancer? Like, why is this affecting me? None of my friends have cancer. On one hand, my older patients might be worried about their grandkids graduating or seeing life events for their family members, whereas my AYA patients are worried about, am I ever going to have these life events myself? Am I ever going to graduate? Am I ever going to have kids in the future? How do I tell someone that I have cancer on a first date? These are all just really different priorities that our AYAs have compared to our older adults. And I think because of this, when you're treating an AYA patient, you really just have to have a different mindset of how to treat them. AYA patients just automatically require different treatment options, different supportive resources, and different survivorship care. And it's important for healthcare providers and other physicians, to be aware of this and to be trained in this. And you could take my word for it, but the literature also supports this idea. So unfortunately, despite the many advances in cancer over the past 10 years, AYAs still have a worse overall survival in leukemias, lymphomas, and some solid tumors like sarcomas compared to children who have these same exact cancers or compared to older adults who have these same exact cancers. So what's to blame for these key differences in survival between other generations of cancer patients and the AYA population? Well, us researchers in this field really blame something called the AYA gap. And so this AYA gap is actually a historical observation that improvements in cancer survival rates for AYAs have long lagged behind those seen in advances in survival in children and older adults with cancer. And researchers like myself have pointed to 5 main reasons as to why this gap exists. The first is clinical trial participation. AYAs have a notably low rate of participation in clinical trials, often below 10%. And to compare with what rates are in adults at the same institution, it's anywhere from 30 to 50% based on the institution. This low clinical trial participation really limits our understanding of disease biology in this group, and also really prohibits us from developing age-appropriate treatments. As we have discussed, AYA patients have decreased survival rates compared to other generations. And yes, while we will talk about that, a lot of this has to do with the disease biology that affects AYA patients, it also has a lot to do with insurance issues and just frank lack of access to care. AYA patients also face really unique psychosocial challenges, including maintaining independence, coping with treatment side effects, managing financial hardships, and they often do this on their own or with their parents who they're trying to become more independent from. These issues are compounded by a huge lack of age-appropriate information and support services for them specifically. And if anyone's tried to transition from one hospital system to the next, you know it's incredibly frustrating. So the transition from pediatric to adult healthcare is actually much more abrupt than just going from one adult institution to another. It's poorly managed, and all of this really leads to fragmentation in care and adverse health outcomes. And finally, education. There's a significant lack of formal AYA-focused education in oncology fellowship programs, which really impacts the quality of care that's provided to this population. Now, my friends who are trained in pediatrics get a lot of information on the AYA population because that's just built into their fellowship. But for myself, who is an adult oncologist and I trained in an adult institution, that's not the focus on a lot of our fellowship testing, and it's not the focus on a lot of our fellowship curriculum. And it really wasn't until I was in a clinic that focused on AYA patients at my fellowship that I was super interested and got to understand this population a bit more. But I will say there is hope. More and more people and physicians are becoming aware of this AYA gap and how it negatively affects our patients. So there are more and more conferences and symposiums that are happening to bring together healthcare providers to collaborate and conduct research. These are just 3 conferences that happened over the past year that I was able to attend. There are also more advocacy groups and even an AYA awareness week now. And this all kind of brings advocacy to, bring light to this critical topic in the general population. Now, all of this advocacy and research has actually led to very specific guidelines for healthcare providers on the treatment for AYA patients. So the NCCN, or the National Comprehensive Cancer Network, publishes guidelines on all types of cancers to help oncologists stay up to date on the latest research and developments. So the NCCN thought it was so important to create a specific guideline or manual for oncologists to truly understand and improve the treatment of the AYA population. And they updated these guidelines in September of 2024. Again, this guideline is really intended to help improve outcomes and help providers optimize their treatment of AYA patients. But what I also really loved was that the NCCN came out with a guideline for patients, so that AYA patients can go to the NCCN guidelines and read things that their providers should be focusing on to really keep them informed and make sure they're an active participant in their care. Specifically, the NCCN AYA guidelines cite 3 broad themes that they say will help close this AYA gap. And these are the 3 themes. So first, encouraging physicians to use AYA-specific cancer treatments, including clinical trials. And we'll talk about that in the rest of my talk. 2, they recommend that we advocate for supportive clinical resources for AYA patients, especially focusing on things like fertility, patients going back to work, mental health, and social work support. And then third, they really focus on bringing survivorship care to the forefront of a patient's mind so that physicians can tailor cancer treatment with survivorship and long-term survivorship as a goal for the patient undergoing treatment, so that they're not dealing with side effects of their cancer treatment for the rest of a very hopefully long life. And as I mentioned kind of initially, I will be touching on all of these themes. And the first one that I'm going to be talking more specifically about is treatment of AYAs with blood cancer. And because I'm a leukemia doctor and I treat patients specifically who have acute lymphoblastic leukemia, we'll be talking about that a lot today, because that's where a lot of the literature is important in trying to shape how we treat AYAs with blood cancer. So again, I won't belabor this point because it's depressing and we've talked a lot about it, but yes, AYAs have a lower overall survival compared to children treated the exact same way for leukemias. And, you know, as someone who's kind of entrenched in this, I always thought that this was something that people knew. But like my dad, I was talking to him today about this talk, and I talk to him all the time about my research. And even he was like, oh, but young people do well when they get cancer, right? Not always. And, you know, one of the reasons for this specifically in ALL and other leukemias is because AYAs actually tend to have more aggressive disease. And what that means is when we look at the leukemia in an AYA patient, it behaves more aggressively than the leukemia in children or leukemia in older adults. There's been a lot of research into ALL outcomes in older adults, and so the overall survival in that population is improving a little bit more than it has improved in the AYA population. But I would say the good news is a lot of studies have been done to try to improve outcomes for AYAs and ALL, and it's worked. So prior to 2008, standard of care of AYAs in the adult world was to give AYAs the same chemotherapy regimen as adults. But standard of care in the pediatric world was to give AYAs pediatric chemotherapy. The difference between pediatric chemotherapy and adult chemotherapy might not seem that much, but pediatric chemotherapy tends to be a lot harder to tolerate. The treatment lasts about 3 years. It's very vigorous, versus the adult regimen tends to be a little bit easier to tolerate. It's not as long. It's not 3 years long. And so that's why a lot of people were using that treatment for AYA patients. So to kind of drive this point home, imagine the scenario. You have an 18-year-old male or 19 or 21 who gets diagnosed with ALL. If that patient goes to their pediatrician, because maybe they're still under their parents' insurance and they're able to see their pediatrician, if their pediatrician is happy to see them, if they get diagnosed under their pediatrician, they're going to be admitted to the pediatric hospital. And if they get admitted to the pediatric hospital, they'll get admitted to the chemotherapy ward. And on the pediatric chemotherapy ward, things are all like happy, right? There's like fairies and rainbows, and there's, you know, lots of dogs that come and visit. Like there's just, the pediatric ward is focused on, you know, making that a really happy environment, which for like an 18-year-old male might not be the vibe they're going for at that moment. But in a more medical sense, that patient's also going to get a classic pediatric chemotherapy regimen. And they're going to be seeing doctors who are used to giving this pediatric chemotherapy regimen and used to understanding the side effects of that regimen. Now go back to that same 18-year-old male, and let's say that they saw an adult doctor. So maybe their pediatric doc said, oh, you're 18, I don't want to see you anymore. And they end up going to a new primary care provider in internal medicine, and they get diagnosed with ALL. They're going to end up at the adult hospital. And in the adult hospital, they're going to get treated like an adult. There's not going to be a lot of resources for them that might be age appropriate. there's not going to be a lot of support or a lot of money for support for them to go back to work. They need to figure out how to stay on their insurance because they're not going to be able to get treated at the adult hospital without adult insurance. And so it's two totally different experiences. What's more important in the adult version that we'll talk about is that that patient would most likely get an adult chemotherapy regimen. So if you think about it, it's two ways to treat the same exact patient, all based on what doctor you saw. So no wonder it was so hard to measure outcomes in the AYA population in the 90s and 2000s. Then one of my favorite researchers and clinicians in this field, Dr. Wendy Stock at the University of Chicago, noticed this discrepancy. She's an oncologist at an adult center, and she saw this happening and wondering if we should be treating AYAs like we treat pediatric patients or like we treat adult patients. And interestingly, her study in 2008 showed that if you treat an adolescent and young adult with a pediatric chemo regimen, they have a better overall survival and their cancer is more likely to be cured than if you treated them with an adult regimen. And this is why most academic centers are trying to use what's called these pediatric chemotherapy regimens for AYAs. And more recently, kind of fast forwarding from 2008 to 2024, we started questioning this and how we determine if an AYA has aggressive disease versus not aggressive disease. So this concept was published earlier this year in 2024. And kind of to explain what they were trying to test, as part of standard of care, when a patient comes to me with leukemia, I do a bone marrow biopsy and I use two things. One thing is called molecular tumor testing. And what molecular tumor testing is a way to actually look at the genes within a cancer itself to determine how aggressive that cancer is. I also use something called minimal residual disease testing, or MRD testing. And MRD testing is a way that after a patient has had treatment, I'm able to look with very specialized laboratory tests to determine if there are a teeny tiny number of cells residing in the patient's body that I can't see on lab tests or under a microscope with my own two eyes. And the reason this is so important is because it really determines how I treat a patient. So if I get those results back and a patient is deemed to have more aggressive disease based on these two tests, I'm going to use more aggressive treatment. A lot of those patients, if not all of those patients, I'm going to recommend doing an allogeneic stem cell transplant on, which is a really aggressive form of treatment. But if I get these tests back and the patient is low risk, then I'm going to use less aggressive treatment. And I'll probably have the same end result and with a lot less side effects. However, it's really important to know how risky or how aggressive that patient's leukemia is. But the researchers that performed this study had a very specific question. We know that AYAs tend to have more aggressive disease. So do these classic risk categories really apply to them? And what they found was no, not really. So when they performed this study, they looked at the MRD testing and the molecular testing of 57 AYA patients with ALL and treated them as we would treat adults. And what they found was that AYA patients who had low risk leukemia actually their disease behaved more like high risk leukemia. So what came from the study was a lot of ALL doctors and researchers are saying, wow, we need to completely rethink how we determine whether an AYA patient is high risk and needs more aggressive disease or whether they're low risk and needs less aggressive disease. So now that we've talked a lot about treatment of AYA patients with leukemia, I want to switch gears and talk about supportive care resources and why this is so important for AYA patients. So as a clinician, clearly my goal with all of these cancer treatments is to cure my patient of their cancer. But the question we often ask ourselves is, at what cost? One of the most life-altering treatments we put our blood cancer patients through is called stem cell transplant. And so for the patients who, or for people on the call that may not know about stem cell transplant, essentially what it is you take the stem cells of a donor, which essentially is their immune system, and after a lot of treatment, we infuse it into a patient with the hopes that this new immune system is going to kill the leukemia. It's very aggressive. It's not an easy thing to go through, and so if we can save people from transplant, we would really like to. But the more we learn about transplant, we learn about how important it is in curing high-risk patients with ALL. And so we are offering it, especially because we're really good at doing transplants now. We've learned a lot over the past 10 years, and we can really minimize some of the side effects of transplant that these patients might deal with for the rest of their lives. Now, one of the ways that we're able to learn about side effects that patients have are to study survivors of patients who've undergone this stem cell transplantation therapy. And there was a super important study that was done by the CIBMTR. And the CIBMTR is a national organization that does research on all of the transplants in the US. And they did a study on quality of life of transplant survivors who were over 10 years after their transplant. And what they found was that older adults have actually the same quality of life as age-matched people in the general population who had not undergone stem cell transplant. But when they looked at AYA patients who were 10 years out from their transplant, they actually had worse mental health, and they were much worse at navigating healthcare systems 10 years after their transplant compared to age-matched people in the general population. So while AYA patients, might be in better physical health than older adults that are undergoing their transplant, they still have a lot of psychosocial issues that we really need to help them with. And really what this did was this caused the CIBMTR to advocate for better supportive resources for our AYA survivors and AYA patients undergoing treatment. And improving supportive care and mental health resources for patients was something being worked on at UT Southwestern long before I joined. Dr. Brittany Hall and the AYA research team in the psychiatry department have really done great work at improving care for patients here at UT Southwestern. Some of you who work in our clinic or who have been to our clinic might have seen this AYA psychosocial screener. And the screener doesn't only just help us identify specific things that could be stressful for our patients, it also aims to provide electronic resources to help support them. So I've personally used this screener in my clinic, and I think it's a great way to open up conversations with your patients in a way to talk about things that might be complicating their therapy that won't come up in a normal clinic visit. So this is an example of what a screener might look like. And as you can see, our patient was really worried about their career. They were really worried about some anxiety with their healthcare management, and then they also had a lot of sleeping difficulty. These are probably the top 3 things that my patients are all worried about. And what the psychiatry team did was once they received these screeners, they then sent patients personalized care plans that included resources to the topics that they were really concerned about. And I really want to take a moment to congratulate the AYA PsycOnc team for their work, because feedback of the patients who went through this initiative was overall very favorable. Patients reported that the care plan was beneficial. It helped them engage in the AYA support community. They report being better educated about their disease processes as well. And because of this, they were able to publish this initiative, and now other centers are able to use what we did at UT Southwestern to really better the care of their own AYA population. Another way we can improve outcomes for AYA patients is by the creation of an AYA program or a center of excellence. So this has been proven so beneficial that even the NCCN guidelines in 2024 recommended that all AYA patients be referred to AYA centers of excellence. Now, this isn't always feasible, but they did say that if you are able to refer a patient to one of these centers, definitely do it, because patients who are referred to these centers of excellence have improved outcomes compared to patients that don't get AYA-focused care. And the way that they were able to study this was they took an entire database of all ALL patients in the nation, and they focused on AYA ALLs that were treated specifically at an AYA specific site or an AYA center of excellence that had a program, and versus those that were not treated at an AYA specific site. And they actually found that the patients treated at an AYA specific site actually had better overall survival. So they lived more and lived longer compared to patients that were not treated at an AYA program. But studies show it's not just important to go to an AYA program, it's probably more important to go to a joint AYA program, or a program where both pediatric doctors and adult doctors talk about AYA patients. And the way that these joint programs improve patient outcomes is they increase clinical trial enrollment, they optimize treatment selection, and they provide age-appropriate resources and care for the AYA patients. This was highlighted at the University of Pittsburgh, actually, which when they were able to join their children and their adult programs, they saw a 20% increase in clinical trial enrollment just by joining the two programs and having quarterly meetings to talk about their patients. So because of this, Children's and UT Southwestern have joined forces to create an AYA task force and to form a joint AYA program. And I'm proud to say that since joining forces earlier last year, we already have 2 approved clinical trials in the pipeline that will be open at both sites. So I'm really excited to see what this AYA program is able to do and how we'll be able to use it to help our patients. So the final thing I want to talk about is, again, something that I'm really passionate about because I think it's super important, but specifically tailoring survivorship care to AYA patients. I always think it's really interesting to compare what my patients are concerned about with their treatment versus what I'm concerned about, because sometimes it aligns, but I would say maybe more often than not, it doesn't always match up. And in terms of survivorship, studies are clear and really show that AYAs consider these topics really important. And so you can see that when you kind of talk to a bunch of different physicians about what their concerns are in the AYA population, some things definitely don't match up, right? Like physicians are really concerned about side effects and late effects of their treatment, but AYAs put that as number 7. Something though I think is important to highlight is that both AYA patients and physicians list fertility preservation as one of their top 5 concerns in cancer treatment. And I want to focus on this because I think that fertility preservation and sexual health is something that everyone is kind of scared to talk about, despite being something that everyone's really concerned about. In fact, a recent study sadly showed that only 50% of AYAs reported a provider discussing fertility preservation options before their cancer treatment even began. And to me, this is really sad because for a lot of patients, we can actually do something to help preserve their fertility before starting a life-saving cancer treatment. And often this exact scenario that's pictured here happens in my survivorship clinic, where patients say that the most education that they got from their healthcare providers during treatment was that they couldn't get pregnant after treatment and that they were going to be infertile for the rest of their lives. And you know, my patients aren't alone. AYAs report that they received limited sexual health education and limited support for sexual health during their treatment throughout the United States. And when we ask and we survey healthcare providers why, they say, well, this is kind of an uncomfortable conversation to have when you're trying to save someone's life. But then they also report having very limited knowledge and education on the topic itself. So yes, while the healthcare providers that are telling our patients that they'll be infertile after treatment are not totally wrong. We know a lot of patients experience infertility after blood cancer treatment, but I think it's important to know that some patients are maintaining their fertility And some patients do go on to have babies, especially if we talk to them early about fertility preservation. One of the most toxic cancer treatments and a high reason for infertility amongst blood cancer patients is an allogeneic stem cell transplant. Now, the primary mechanism of this is the chemotherapy is toxic to the ovaries and the testes itself. And so a lot of the times in females who undergo allogeneic stem cell transplant, they will have high rates of 60 to 70% of premature ovarian failure kind of post-transplant. In males, infertility is also common, with low sperm rates happening in about 40 to 70% of males who undergo an allogeneic stem cell transplant. And so these high infertility rates made doctors really think that pregnancy after transplant was impossible, that no one would be able to get pregnant after transplant. But I think my favorite study that was published in 2024 is really changing the view of physicians and transplant doctors worldwide. And this study was called Hope for Motherhood. It was a study that was done in Germany. They researched all women who underwent an allogeneic or a donor stem cell transplant in Germany between 2003 and 2018. And what they found was pretty incredible. Out of approximately 2,600 women of childbearing age, there were a total of 74 pregnancies, or one pregnancy for every 50 women who got transplanted. Now, for someone who's not a transplanter listening to this, I'm sure you're like, wow, 1 in 50, that seems like a super low rate. But to a transplanter, this is incredible. This is much, much higher than we ever thought possible. And I think what was more important was the detailed information that came out of this study of how these women got pregnant. So they were able to obtain detailed information on pregnancy outcomes of about 32 women who had 54 pregnancies. So if you see here, these are the patients, and some of these women were able to get pregnant multiple times. So the column here on the left is all of these patients who and their pregnancies, and then these columns here on the top are how they were able to get pregnant. So what reproductive methods were they using? And what's super interesting to me is about 72% of these women were able to get pregnant spontaneously, meaning they didn't have to do egg preservation, they didn't have to do IVF, it just happened after transplant, which again, we're telling our patients that this isn't possible, but hey, it actually was possible. The rest of the women, about 28% of the cohort, ended up using a method of fertility preservation or reproductive technology in order to get pregnant. And this figure really highlights some of those reproductive technologies that worked. So egg donation, so getting an egg from a donor and implanting that into the patient was the most successful. But for patients who desired a natural conception of their own, ovarian tissue cryopreservation was the most successful. And I want to take a moment to talk about ovarian tissue cryopreservation because it is relatively new to the US. You know, if you look at the NCCN guidelines, they really advocate for egg preservation or egg oocyte cryopreservation, or essentially egg freezing. But ovarian tissue cryopreservation has been used for a long time in Europe and has shown to really have successful outcomes. The clinical pregnancy rate of ovarian tissue cryopreservation is about 43%. And this is actually a little lower than egg cryopreservation or oocyte cryopreservation. So what is ovarian tissue cryopreservation? Well, it's a surgical procedure where an ovary or part of an ovary is removed and it's frozen or cryopreserved. Once the patient's done with chemotherapy, that patient can have the ovary re-implanted into them and it starts working on its own. And so sometimes we do have to use reproductive methods like hormonal treatments to kind of help stimulate that ovary for the patient to have a natural conception. But as I mentioned, it led to a clinical pregnancy rate of about 44% and the live birth rate of about 33%. So this is widely used in Europe. The other nice thing is that it doesn't require hormonal stimulation and it doesn't require a treatment delay. So a lot of our patients who undergo egg preservation, they can't actually do it because it takes about 2 weeks to stimulate and collect the eggs. And sometimes we don't want to wait that long to start treatment. Another benefit is that you restore hormonal function after implantation, so these patients don't end up in perimenopause after they have their stem cell transplant. So in conclusion, adolescents and young adults are a unique and vulnerable population who tend to have a lot of poor outcomes. Improving clinical outcomes really requires improved research, supportive research sources, and careful consideration of AYA-specific needs. I do think healthcare providers really need to be advocates and educate their fellow colleagues to enact change. And really just better advocacy, continued research, and frequent discussions with patients about their concerns can only improve AYA care in the future. So thank you everyone for listening to my talk. It's again, something, I think I was telling Alex I'm a nerd, and this is something that I'm really excited about. So thanks for being here. I do want to thank Alex for her awesome introduction, and honestly for being a fabulous director of supportive and integrative care and really helping my patients. And of course, I need to thank Tia, who is our essentially support dog around these parts, and I just love her so much. I also want to give a shout out to the Dallas YACS, or the Young Adult Cancer Support Group. So for any patients who are in the audience, YACS is a fabulous group and a fabulous support tool. They also have a newsletter, which Alex will kind of give you information in the follow-up email of how to sign up for that. But I love getting the newsletter every month. It's so much fun. Also, I want to thank my clinical support team. I would be remiss if I didn't thank my nurse, Elizabeth DiFrancesco. She loves this patient population so much along with me, and it's so much fun to be able to care for our patients in this environment. And also I want to highlight some of the AYA resources we have. And again, in the emails after this, you will be getting different link to this resource if you're a patient and you want to investigate these things. And then most importantly, I know some of my patients are on this call. Thank you so much for entrusting me with your care. I am honored to be able to take care of all of you. And yeah, I'm happy to talk to anyone about any questions.
Thank you, Dr. Irizarry Gatell. That was really, really interesting and informative. And I do see some patients on this call that I know are very grateful for the care that you've given them and continue to give. We had a couple of pre-submitted questions. And again, if you have questions, feel free to go ahead and put those in the chat and we will try to get to those. The first one is on the long-term impacts of stem cell transplant, bone marrow transplant. For younger patients, what are those long-term side effects? Do those change over time, including risk of relapse? How does that number move the farther you get from transplant?
Yeah, that's a really fabulous question. You know, we say for a lot of our patients that your risk of relapse really drops significantly after 5 years after your transplant, so much so that relapse after that is pretty unheard of. But what's really concerning and what I think doctors are really looking out for is secondary cancers. So oftentimes with a lot of the treatments that we give patients, they can end up with secondary skin cancers. And it's probably why your doctors are telling you to stay out of the sun all the time and that type of thing. So secondary skin cancers are a big one. The other side effects are kind of what we in the medical world call endocrinopathies. So thyroid issues. A lot of patients become hypothyroid. Premature menopause, which we talked about, is also a big one. So the other thing to note is, I've had AYA survivors in my clinic that have just really weird things happen to them, right? Like weird medical things that their doctors don't always pick up because they're like, oh, you're too young to have this. But I remind my patients that, and I remind all of these other physicians that I partner with, that going through a transplant is almost like accelerated aging. And by undergoing a stem cell transplant, you're kind of predisposing yourself to things that older adults might get. And so that's why I think it's really important for patients to go to a survivorship clinic at least once a year to kind of make sure that your doctor is checking for those things and talking to the rest of your healthcare team to make sure everyone is looking out for those.
Awesome, thank you. Let's see, we've had a couple of submissions here to the chat. One, going back to the cryopreservation. Why might we be behind Europe in using cryopreservation, especially when we're using the same technology in pre-cancer cervical cells, breast cancer treatments? Can you speak to that a little bit?
Yeah, absolutely. I think what you'll, and nothing against Europe and nothing against the US. In the bone marrow transplant world, we're essentially one and the same. All of our conferences are joint Europe and US, and we talk to our European colleagues all the time. But I just think the priorities are a little bit different. So in Europe, there's a lot more focus on preventative care, and ovarian tissue cryopreservation is essentially a preventative care. And so they really have put a lot of money into trying to um, kind of preserve fertility and honestly preserve ovarian function for a lot of women, because premature menopause really causes a lot of issues down the line, like osteoporosis and diabetes and heart disease. And so I think that's why Europe is probably a little bit ahead of us, is just because they're trying to prevent osteoporosis and other healthcare problems associated with menopause.
Okay. This is also on the ovarian tissue cryopreservation. Who offers it in the area? I don't believe it's something that UT Southwestern currently offers. Is this something that the partnership with Children's opens the door to?
Yes. So Children's currently offers ovarian tissue cryopreservation kind of in a partnership with UPenn up in Pennsylvania. And we have been able to send patients kind of on a case-by-case basis to Children's in order to get this done. We are trying to open that same thing here. Our gynecologists here are really excited about ovarian tissue cryopreservation, and they really want to offer it to our patients. We're just kind of like going through the paperwork and trying to figure out where we would cryopreserve these ovarian tissues. But yes, that is definitely something we're looking into. For patients who cannot get it in the Dallas-Fort Worth area, the only other place in Texas that offers it is MD Anderson.
Thank you for that. I know that is helpful for many who are part of the treatment plan and trying to coordinate and navigate patients. This question is, how can we better personalize treatment intensity to reduce toxicity without compromising efficacy in AYA patients?
That's a fabulous question. So that's something that is such a it's such an active form of research in UT Southwestern and just in transplant in general. And, you know, a lot of questions go into using those molecular studies. So can we use the MRD status of a patient to say, hey, if you're MRD negative before treatment, do you really need to undergo hefty doses of chemo to get your transplant to work? Or is there lower chemotherapy that we can use? And, you know, it's really tough to do those studies because you never want to give someone a lower dose of chemotherapy at the expense of then increasing the risk of relapse. And so those are delicate studies that are being actually performed at the national level. And so I think in the next couple of years, we'll know a little bit more about how to better do that.
This is a follow-up question, which I think you answered partially, but you may have some more to weigh in on. Are they developing more age-specific protocols using molecular targeting, making age less relevant?
Yes. So in general, in the leukemia world and in the transplant world, just in blood cancers in general, we are really trying to focus on the patient and disease specific characteristics and tailoring treatment to that. So we're kind of trying to move away from just blanket treating everyone the same way. And we're trying to say, okay, what is really driving your cancer and how can we target that rather than just trying to destroy you with a bunch of chemotherapy?
We clearly have some savvy guests. So here's another question. How may epidemiologists help contribute to closing the AYA gap?
Oh my gosh. just come talk to me.
I was gonna say these are your people here on the call.
Yeah, so I actually partner a lot with epidemiologists to really identify what are the concerns of the AYA patients that we're not addressing with our cancer treatments. So a lot of the research I've done has been in sexual health in patients undergoing transplant and CAR T-cell therapy. And it really just gives you insight into what patients are interested in. So I think how epidemiologists can help is really doing those kind of broad PRO or patient-reported outcome studies that allows us to really then go back to the treatments we're giving those patients and say, okay, our survivors are really worried about X, Y, and Z, or we're seeing X, Y, and Z things happen in our survivors. How can we tailor our treatments on the front end to on the back end without decreasing or without increasing the risk for relapse?
All right, here is a question about clinical trial navigation. Do we have clinical trial navigators or lay navigators that are dedicated to assisting patients in navigating those barriers, AYA patients specifically?
Yeah, that's a great question. So that is something that we're working on with the AYA task force. And maybe another resource we can put in the chat is the website that has our clinical trials on it. Most nurse navigators in our clinics are going to be able to really identify a physician who treats your disease specifically. So if an ALL, AYA says they want to come to UT Southwestern, the nurse navigator is going to put that person in my clinic. And really it's the attending then who can help you look at the different clinical trials that are available. But if patients want to go and research themselves, there are a couple of websites that they can do that too.
Okay, this one question takes us back to fertility preservation, specifically in men. Often male patients are told to refrain from pursuing fertility or having children until a certain duration has elapsed since treatment. Do men have options to expedite pursuing having a child faster after treatment?
Yeah, that's a really good question. So there's actually testicular cryopreservation is experimental both in Europe and in the United States. And so I think once that becomes approved, that would be an option for men to have children faster or earlier. The reason that we tell patients to wait about 3 to 6 months after treatment is because of how the chemotherapy affects your essentially your sperm count, but then also the quality of your sperm. If the chemotherapy can really affect genetic material, and we don't want a person getting pregnant and having genetic abnormalities in that pregnancy. But more to come. I agree. I think that men, unfortunately, in the fertility world are kind of not thought of first. We always think about women and how women can have better fertility preservation, but men are just as important. And I've had a lot of patients tell me like, oh, I was told I could never get someone pregnant, and then now I have like 2 kids. Like, and so I think way more education needs to happen around men fertility, and more research definitely needs to be done.
Okay, this question, instead of RCTS, hold on, my screen moved. Is there evidence to support emulating target trials in the AYA population with leukemia?
Yes. So the AYA research world is pretty small. So we all meet pretty much twice a month to try to figure out how we can better tailor treatments and trials to AYA patients. And so I'm actually really lucky to be on a couple of boards, like advisory boards for national organizations like the Transplant Organization, ASTCT, and the CIBMTR. And my entire goal as being on that board is to advocate for these studies to include AYA specific concerns and to also make sure that they're tailoring these trials to AYAs. And so I think because people are becoming more and more aware of it, and there's more adult oncologists that are becoming interested in this population, we'll just continue to see the research in this grow.
All right, I think we have time for one more question, and the last one I see, and this might be one we can answer together. So I'll turn it to you first and then maybe chime in too. Supportive resources for financial reimbursement to assist with the financial toxicity that is all of our patients, but particularly young adult patients. What are those resources? Where might patients go?
Yes. Oh my gosh, it would be my dream to have like a financial counselor, and that is, you know, written in our proposal for this AYA program, is like having a financial counselor specifically for AYA patients. But at the moment, really the best place to go is your friendly social worker. So if you just ask your care team to talk to social work about financial resources, that's a great place to go and to start. Our leukemia social worker, Larissa, is amazing, and she finds grants and money for patients. And I'm just like, I don't know how you do this. Like, I don't know if I have time to look through all of the grants and things that are available to patients, but she does it. And so I think that really just ask your care team. It's really hard to do that because, you know, I think no one really likes to talk about money, but financial toxicity is real. And especially in the AYAs who maybe are trying to work and keep their insurance, but then they're having to take FMLA and getting paid less. Like it's a huge deal. So yeah, definitely just reach out to your friendly social worker. And I don't know, Alex, if you have any other resources.
Well, you stole my number one. Always ask to speak with your social worker. And as you mentioned, proactively. I know that patients tend to do this after the bills start coming in, but if you're newly establishing care, go ahead and make that relationship with your social worker because resources open and close and ongoing, monitoring of what's available and when. Another great resource is the Leukemia Lymphoma Society. They have some amazing resources, financial assistance resources for patients. And again, great place to start as your social worker, check out their websites, and we absolutely can walk through those application processes. All right, well, we've covered all of our questions. We've covered a ton of information. There is a lot of data here and also a lot of hope. And I really appreciate you really underscoring that throughout the presentation. As we mentioned, more resources to come in the email. So there were some questions about that, and you'll get the recording along with some information about the young adult group that we facilitate and some additional resources too. And this series is going to take a little summer hiatus and we will be back. So good news is, since you're registered, you'll get emails about future Lunch and Learn sessions as well. So we look forward to seeing everybody in the future. And thank you again for spending this hour with us.
Thank you. Thanks everyone for joining.